Evaluating a patient immediately after balloon mitral valvotomy, which is also known as percutaneous transmitral commissurotomy, is one of the more hemodynamically complex scenarios in the echo lab. Because the procedure abruptly alters valve geometry, chamber compliance, and interatrial shunting, the standard resting measurements we rely on often contradict each other. The disconnect in mitral valve area. Immediately post BMV, the reliable triad of planimetry, pressure half time, and the continuity equation frequently give highly discordant values. Inaccuracy of pressure half time. This is the most significant pitfall. PHT relies on a stable relationship between left atrial and left ventricular compliance. BMV causes an acute sudden drop in LA pressure and a rapid increase in early diastolic transmitral flow, temporarily decoupling this relationship. Consequently, PHT often significantly overestimates the mitral valve area in the first 48 to 72 hours. Irregular orifice in planimetry. While 2D planimetry remains the anatomical gold standard, successful commissural splitting leaves a complex irregular or teardrop-shaped orifice. Gaining a true short-axis cross-section exactly at the tips of the newly torn leaflets is technically demanding. Continuity equation confounders. If the procedure induces mitral regurgitation, transmitral stroke volume no longer equals aortic stroke volume, rendering the continuity equation mathematically invalid. Quantifying post-procedural mitral regurgitation. BMV inevitably alters the coaptation line. While mild MR is a common and acceptable trade-off for a larger valve area, acute severe MR requires immediate intervention. Eccentric jets. New MR post-BMV is rarely a clean central jet. Commissural tearing or subvalvular damage creates highly eccentric jets that hug the LA wall. Relying on color flow jet area alone will drastically underestimate the severity. Multiple orifices. You will frequently encounter a pre-existing central regurgitant jet combined with a new distinct commissural jet. Proximal isovelocity surface area (PISA) and vena contracta become highly flawed when trying to quantify multiple non-circular regurgitant orifices simultaneously. Differentiating therapeutic splitting versus structural damage. The goal of the INO balloon is to split the fused commissures. The diagnostic challenge is confirming whether the increased valve area comes from this therapeutic splitting or a procedural complication. Commissural versus leaflet tears. A tear in the anterior belly will increase the functional orifice but result in catastrophic MR. Three-dimensional transesophageal echocardiography is often required on the table to definitively map the location of the tear. Rupture of subvalvular apparatus. The balloon or guide wire can ensnare and rupture chordae during inflation or withdrawal. Identifying a flail leaflet segment amidst a heavily calcified, distorted, rheumatic subvalvular apparatus can be visually challenging on standard 2D transthoracic echocardiography. The iatrogenic ASD. The mandatory transseptal puncture leaves a persistent iatrogenic atrial septal defect that actively interferes with post-procedure assessment. Hemodynamic masking. A significant left-to-right shunt across the ASD lowers LA pressure. This can artificially lower the transmitral mean gradient, giving a false impression of a highly successful valvotomy even if the absolute mitral valve area gain is suboptimal. Flow reversal. In the setting of acute severe mitral regurgitation caused by the procedure, the ASD acts as a pressure pop-off valve. You may observe right to left or bidirectional shunting depending on the compliance of the right atrium, which can mask the true severity of the left atrial pressure spike.